said, I do not recall there being obese children in our classrooms. Today, you see them all the time. And they were like, well, yeah, I think you might be right. And I'm like, well, I'll tell you what, I'm going to go and I'm going to get one of my class pictures. And I do this for a reason, though. This was a little over 50 years ago in the 6th grade. Well, I'll tell you what. And if you look real close at that picture, you do not see any children that are obese. Again, I don't recall seeing children when I was going through school that were obese. There's 31 children in there, plus a teacher. And out of the 31, if you look real close, you might find 2 of them that are slightly overweight, okay? So that's basically about 6% of that class would be considered overweight. There's nobody in that class that is obese. We take a look at some charts here. And these charts are basically, these are some older charts. I had to go back and pull some older charts here from the CDC. But if you'll notice on the left-hand side, and there's 3 different age groups there, but notice that back in the late 60s and early 70s, that class picture pretty well represents what they were seeing in the data, the survey data, dealing with children and adolescents that were overweight. You can see that it was hovering right there around 5%. But as you move to the right, you see that the children continue to get heavier in these surveys. And of course, these surveys here actually stopped in the early 2000s, but we were already approaching close to 20% of the children were reaching the overweight stage. As we mature, these are some more charts, and I'm sure you've already seen these charts, but this just kind of breaks out the country in the different levels of obesity of the adult population. So as these children, as you grow older, everybody gets a little bit heavier. And you'll notice that Alabama is right there, it's in the red. According to CDC, about 35 to 40% of the population is obese. Now I will tell you, and you will see in a few minutes, that the state employee population is actually much higher than that. And there are some reasons why we're much higher than that. But if you look at Alabama, you can pretty much compare us, and we're similar to Georgia, South Carolina, Tennessee. We're higher than Florida, but we're less than Mississippi, okay? So let's dig into the State Employees Insurance Board. The State Employees Insurance Board, we cover 31,000 active employees, 25,000 retirees, and about 44,000 dependents. So we're just a little bit over 100,000 members in our program. So it's a good population to do some studies, and we'll be sharing some of the information that we have on this population. Before we get into this, I know there's always the debate of, why do you cover some things and you don't cover other things, okay? And it usually comes down to money. And if you'll notice here, these are the trends of the State Employees Insurance Board. The top one is basically the expense trend. You can see over the last 14 years, the trend line has actually stayed fairly flat. And keep in mind, the headwinds that we're up against is inflation for healthcare plans over the same period of time runs at around 6 to 7% annually. We've been averaging less than 1% annually. So the board has certainly had to get creative in their programs in order to keep the costs down. And we'll share a few things that we've done that has certainly helped in keeping that trend to less than 1%. But one of the biggest motivators for us to keep our trend low, though, it goes back to where does the money come from? Well, almost 80% of the money comes from the state, from the general fund, okay? And so when you look at the blue line, that shows you the funding that we have received from the state of Alabama through the general fund. And you'll notice back in 2010, we received $361 million. You go across the line there, and we've actually only received a 2.7% increase in funding in 14 years. Think about that. So we're now at $371 million, which is less than $10 million increase in funding for 14 years, trying to run a health care plan where inflation consistently runs 6 to 7%. So again, you have to get very creative to make the numbers work. The bottom line there is the amount that the member pays. They pretty much pick up the difference that the state's not contributing. And you can see there's been an increase there. Their trend is running just below 3% a year increase in contributions, premium contributions to the health plan. But the main number I want to focus on, though, is that blue line. That's the state funding. So as the funding has been basically flatlined, that impacts what programs that we can invest in. Sometimes there's programs we look at and we say we would love to be able to invest in the program, but we don't have the seed money to do it, okay? So let's look at the SEIB obesity experience. First of all, where do we get the information? As we said, we got a little over 100,000 members in our program. The board back in 2009 set up a program. We were the first in the country to set up a biometric screening program. At the time, it was very controversial. Today, you will find that almost every single state employee health insurance plan throughout the country has copied this program because it works. This is basically a very simple program where we do some biometric screenings. We're looking for high-risk factors, whether it be hypertension, diabetes, cardiovascular disease. But one of the components that we collect information on, though, is BMI. And the reason we do that is because we know that we have a very heavy-set population within the state employees insurance program. So the more we can know about these individuals, the better we can put programs in place that will have an impact on improving their lives. The way this program works is if we identify somebody that's at risk, then they're going to get a referral to their physician. We knock down all the barriers. We want these individuals to go and receive the appropriate care, okay? So they'll take their risk, they get their referral, they go see their physician and get appropriate treatment, and in turn, they get a discount off of their premiums for participating in this program. This program gets very good participation levels. We get right at 90% of all our members participate in this program. And to keep in mind, each year we identify about 10% of our population that is at high risk, not just risk, but at high risk. And these are the folks that we get the appropriate care. You get the appropriate care, get their condition under control. That helps bring the cost of the health care down. And you can see through our trends that we just shared earlier, it works. Here's some demographic information on the employee population. And what we know is that down there at the bottom, we stratify the weight levels by, you have your normal to the left. There's 16% of the population, our population, that has what we consider normal BMI level. 29% are considered overweight. 25, almost 26% are obese, stage 1. 16% are at stage 2, and 12.5% are considered morbidly obese. If you take the 3 columns to the right and you add all that together, that adds up to 55% of our population is obese. Now, you remember the stat I showed earlier from CDC. They basically said it was around 40%. So you can see we are much higher as a state employee population. Some of that has to do, though, is we're an older population than the average group that's in the CDC information. Also, just simply the type of jobs that we do as state employees. There's a lot of behind the desk, sitting behind a desk, which certainly leads to more problems with obesity, overweight, and so forth. The impact from a clinical standpoint, we look at these individuals. We stratify them by their BMI levels. Let's take diabetes. And this is looking at how many diabetic cases do we have for every 1,000 members. So if you look at the individuals that are at a normal weight level, you have 38.2 diabetics for every 1,000 in that category. Notice the stair-stepping effect that takes place. As the people get heavier, the number of cases gets heavier. I mean, not heavier, but gets higher. So when you get to the far right in that category there of diabetes, a BMI of 40 or above, which is morbidly obese, we have 239 cases for every 1,000 members in that group. That's 6 times higher than what you would see if you were in the normal group. So again, when you're trying to look at insurance, it's all about ensuring risk. So what we try to do is get as many of those people that are in the categories to the right, shift them to the left, okay? Because if we can reduce the number of people that are high risk, it's going to be more economical for the state to insure this population. Hypertension to the right there, you see the same stair-stepping effect, goes from 137 cases per 1,000 at the normal rate, goes up to as much as 3 times when you get out there to a BMI of 40 and above, morbidly obese, where you would see 460 cases per 1,000. Low back disorders, you have, again, some similar stair-stepping there. And then on the congestive heart failure, you can see also you go from 2.1 up to 11.5. Again, it's about 6 times increase in cases at that higher BMI level. Let's take a look at the cost. And this is based on the state employees insurance plan. We know that the cost of obesity contributes to about 17% of our total cost. You can see again, everything has a stair-stepping effect. The heavier we get, so if you compare to the baseline, you take a overweight person, BMI of 25 to 29, that category would cost $239 more. I fit into that category. So even someone like myself, if I lost 10, 12 pounds, got into the more ideal weight, overall, statistically, I would cost the program $239 less. And you can, again, see the stair-stepping all the way out to a BMI of 40 and above, where it's $2,323 more per member in that category than of the ideal weight. Okay, so when we look at these numbers, and as an insurance plan, you know, we're always looking, okay, is there another way of delivering care that would be more economical? Well, this is a good baseline here of knowing how much does it cost today with what we're doing in each one of these categories. And if we have an alternative way of doing this, you know, whether it be surgery, through drugs, through fitness, whatever it may be, you have to look at what's the cost and what are you currently paying today. Because again, the state funding is what it is, and we have to live with that, so we have to make the numbers work. This is an interesting chart here. This is taking, and we stratified along the bottom, our employees, and these are active employees, not retired, these are active employees, they're still working. And we looked at their BMI, if they had a BMI level of 35 and above, and we stratified along the bottom, their age. Notice on the far left that the 24-year-olds and below, the BMI levels of those individuals that are 35 and above is around 20% of that population, okay? That's similar to the charts we saw from the CDC and the children's, I was showing that by the time they're getting up there in close to 20, it was about 20% of them were considered overweight. So these charts are very similar to what we saw there. Notice how as you get older, you reach age 25 to 29, that percentage that are in that BMI level increases. Well, you would expect that, that you come to work, you're not as active as you used to be, sitting behind a desk, and yes, you start to put on a few pounds. And you continue to see that all the way through an employee's 30s, all the way up to in their 40s, but notice what happens in the 40s. For the state employee population, we plateau out at around 32 to 33% of the active employees that meet that definition of a BMI of 35 or more. As you get a little bit older and get into your 50s and definitely into your 60s, notice what happens to that chart. It starts to really fall off. What's the answer? And that was something when we first saw these numbers several years ago. we wrestled with, like, something's wrong with our data. This just doesn't look right. But then when you get to digging into it, there are some things that are happening here. One, a lot of these folks that are, for instance, my age, we grew up in a different society, a different environment where obesity wasn't an issue. So maybe we were taught how to eat better and how to stay physically active more so than maybe the generation that's coming along today. That may be, could be an answer. We don't know for sure. But some things that we do know about this population, though, is when you dig into these numbers, you will find that a lot of these people, when they got into their 50s and their 60s that had a BMI above 35, they're either having to take a disability retirement or, unfortunately, they're deceased. That is a huge impact. So now all at once it's become personal. That the issue of obesity impacts the quality of life of the individual. And once you get to in your 50s and into your 60s, if your BMI is above 35, the chances that you're still actively employed are not that good. So, you look at this and you say, all right, these individuals, when they got their 50s and their 60s and they had to leave state government, how much is that costing state government? We don't know. But you just lost an experienced employee with institutional knowledge, and now they're gone. Now you're having to bring somebody else in, and you've got the cost of training the new person. So as you can see, there's a lot of things that need to be looked at in terms of the full impact. It goes beyond just the health plan. When you're dealing with state government, it's the workforce itself and the cost associated with that workforce. All right, let's just kind of switch gears. GLP-1 drugs, we have the list there of the names of, and most of you have heard all of the names there. Is it a prescription for change? One thing that, I'm not a clinician. I'm not going to sit here today and act like I'm a clinician. We have one on your panel here, but and I'll let them answer the questions about the clinical side of this. But what the clinicians do tell me, and the doctors, professionals tell me, is that the drug is safe and it's effective. Okay, so from that standpoint, it's not so much a concern of should we cover it because we have safety concerns. That's not it. Okay. So what is the question mark? Well, we do cover it for certain situations. If you're diabetic, we will cover the GLP-1 to treat your diabetes. However, if you are getting it for weight loss, we do not cover it. And so let's look at some of the reasons here. If you look at the cost, this is first of all looking at the state employees insurance plan and what it costs to cover the GLP-1s for diabetics. And you can see in the last 6 years, those costs have absolutely skyrocketed, okay? And just keep the seed in the back of your mind that our funding from the state has been level. So as these costs go up, they have got to be offset somewhere else. So as these costs have gone up, and you can see that the number of scripts, which is the bar, you can see how that has basically stair-stepped up over the last 6 years. I think got some what the actual numbers here were. So in 2018, that blue bar, we prescribed 6,600 scripts. And in 2024, it was a little over 35,000 prescriptions. You look at the little red line, that's how much we actually spent. Back in 2018, the GLP drugs, we spent $3.5 million. This past year, we spent $35.5 million. As I said, went up 10 times. So it's a very significant expenditure in our budget. You look at just this one category of drugs by itself represents 7% of our total spend. 7%. So keep in mind, now we have hospital coverage costs, we have physician costs, we have dental costs. This one drug is 7% of what we spend, okay? And that's only covering it for the diabetics and not for the weight loss. When we look at just the drug piece of it, this one drug, category of drugs, ended up costing us last year 30% of our drug spend. That is very significant, 30%, okay? So we look at if you cover it for weight loss, some of the best numbers come out of the state of North Carolina, and I'm assuming that the committee has gathered that information with other presentations, but they have some good information that just shows what happens, been going on in their plan. And if, back in, June of 2023, they were spending around almost $25 per member per month. If you extrapolate those numbers to our plan, based on the 100,000 members, you're looking at a cost just for the weight loss side of it of about another $30 million that would need to be spent. 35% or so that you would deduct from that number. But still, it's a significant number that if we want to cover it for weight loss, then that's what the state's going to need to look at in terms of funding, of increasing funding just for the weight loss drug. Here's a chart that I know that y'all have already seen, but it's just, the point I want to make here is, in the United States, the GLP-1s are just so much more expensive than everywhere else. And you can look there at some of the other countries where you can actually get the Ozempic for less than $100, okay? I will tell you that if in our program, if we were able to get those drugs at $100, we would not be standing here and sitting here today having this debate. We would cover it because, again, the effectiveness of these drugs is really good. I don't have personally, I don't see an issue, with covering it from the efficacy of the drug. It's been simply the cost of the drug that has been the issue that we cannot overcome. All right, what are other plans doing? Here's a survey that Mercer, which is a national consulting firm, you can see there that on the right-hand side of that chart, you got 7% that cover with no restrictions, 35% that cover it with prioritization. So that adds up to about 42% cover the drugs. And then on the other side of it, you got 40% that are not covering and not considering covering, and 19% that say that they don't cover, but they are considering. So as you can see, there's approximately about a 60-40 split of who covers versus those that do not. Here's what other public sector plans are doing. And I will tell you that at our national meetings and regional meetings of the other state plans, this is the #1 topic, okay? Everybody is trying to find the right combination of coverages. And as you can see, North Carolina just recently had to cut their coverage in order to control cost. Connecticut, in order to reduce costs, basically require that you go through one provider, and there's some educational programs you have to participate in order to get the drug. University of Texas, to reduce costs, dropped the weight loss coverage, drug coverage for weight loss. And then the University of Michigan, they took a different route. They increased the copays to help offset the rising cost. This one is, I find interesting. This is the Mayo Clinic, and the Mayo Clinic put a limit on weight loss drugs for their employees. What's really interesting is the comment over here. The comment is basically very critical of the Mayo Clinic for doing that, because basically you're a hospital, you're supposed to be there to to manage the health of an individual, and yet you're not doing it for your employees. And so my point here is this is a very emotional topic. There are a lot of good examples where people have used the GLP-1s for weight loss, and it has worked very, very well for them. And now they're off a lot of medications, and so there's a lot of positives that can arguments that can be made. But then there's also those that are having to pay for this, having the argument to say, I just simply can't afford it. I don't have the seed money to make the investment into these programs. So when you read that comment, again, it is a very emotional comment that the individual made against the Mayo Clinic. What our members are saying? One thing that we do in our program is we solicit our members' feedback. Each year we get about 8,000 comments that come in, which help us fine-tune our program to make sure we're meeting the needs of our members. And as I read on a lot of these, I'm not going to read all these, but because they're basically all saying the same thing. This is just a sample. I could get you hundreds of comments along these lines. But it just simply, our members are saying the prescription program needs to cover more weight loss drugs, weight loss management, physician and drug coverage. I'm logging in to find out if Wegovy is covered. If not, please cover weight loss drugs. There's another comment that's further on down that's basically saying, why does the state not cover, weight loss drugs? All the other Blue Cross plans are covering. Okay, and there's some truth. I mean, it's not all the other Blue Cross programs, but there are programs out there that cover it. Their employers may say we're willing to pay for it. Other programs will look at it and say we just don't have the money to do it. Okay, so you're going to get all kinds of emotions out there with the membership. I understand both sides, and it's, everybody wishes we could cover it, but also that it be economical. Okay. So, summary of the plan. The obesity impact on our program is almost 55% of the active employees. As you saw in the charts, it impacts the members' health. It contributes to 17% of our total cost, which is about $85 million would be the dollar figure that you would attach to obesity cost in the state employees insurance plan. The GLP-1 drugs, overall safe and effective. The coverage under the SCIB, we cover it for diabetes. We do not cover it for weight loss, and the reason for that is simply the funds are not available to cover the cost of the GLP-1s for weight loss. So this last chart in here, because I just find it interesting, we're trying to figure out what's the solutions. And when you look at the United States, we're running 33% prevalence of obesity. We're the highest, I guess, in the world because, definitely with this survey. And as you work your way down, and I go to the ones that are at the bottom, the Switzerlands and Netherlands and France, all down there at, 11, 13, 14%. And the question I have, I've never done any research, but the question I have is, what are they doing different? What's different with their diets, their activity levels, the environment that they live in? What's different? And I think there's something that could be learned if there was more study, more research into those countries to find out what are they doing right? What are we not doing right? The other thing I look at here, because I'm a CPA, so everything ultimately turns into a number. If you were at the Switzerland or the Netherlands percentage, which is about 1/3 of the 33% that we're at, and you extrapolate that, that's basically a cost of 1/3 as much as what we currently are paying. Well, I just said we're paying, $85 million. Well, if we could knock out 2/3 of it and be more like those countries, that's almost $60 million. Extrapolate that one more time, and it's about $150 to the state rate. Now all at once we're starting to talk about real money that impacts the state and impacts the general fund. So anything we can do to get our percentage down as a state employee population, we need to try to do it. Take you back to the class picture. And the question I have is, what was different in 1972 than what we have today? Because obviously back in 1972, obesity epidemic was not an issue. I don't even know, I would say it did not exist. So something has happened in the last 50 years to cause the obesity epidemic. I would basically say that it's got, obviously, your diet, it's got to do with physical activity, and it's got to do with the environment that we live in. And the best thing I would recommend, other than looking at some of these other countries, but it's also just reflecting back what was different with this population of kids right here. And I would start with the new generation of kids and saying, hey, the more we can create this, a better diet, physical activity, better environment, or at least educate them so that they can make the right decisions as they grow through life. And if you can get to the younger generation, ultimately they will become the older generation, and then you could eliminate the obesity epidemic. But you've got to start somewhere. You know, again, I would love to cover the drugs. But again, it's going to come down to the state's willingness to fund that initiative. So that's basically what I would recommend is you look at what were we doing different and try to emulate that, copy that. But again, I don't have the answers to all of that. And I think that's something that would be the next phase of what we need to be looking at is what do the people who have done it right across over in other countries, and then also what was different with these kids back in that day. Any questions?
Negotiation for prices for drugs, is that something you can talk about?
To a certain extent, yes. With the State Employees Insurance Board, negotiate. Okay, this last time, I think we had 9 pharmacy, we call them PBMs, pharmacy benefit management, but we had 9 PBMs that quoted on those contracts. Within those contracts, there's different phases of it. There's what we'll pay the pharmacy. That's the average wholesale price discount that we get there. But then there's also manufacturer rebates. Okay, and a program such as PBM receives on rebates has to come back to us. The only thing the PBM can charge us is just an administrative fee. They're not allowed to do what we call spread pricing or anything of that nature. But, but as far as negotiating outside of the PBM, just going straight to a manufacturer, it's not that simple. I will tell you that the 2 largest manufacturers make regular visits to our office. I have approached them several times of, you know, come up with some kind of pilot project, you know. But there's limitations in even what they can do within, you know, the federal laws and all. But we are certainly open to whatever it takes to get the cost of those GLP-1 drugs down so that we can do or can provide coverage for our population. But big picture, most of it goes through the PBM. But yes, I've had probably over the last 3 or 4 years, close to, you know, probably 10 visits, you know, where we have sat down with the manufacturers, representatives, and tried to see, you know, what can we do.
Do you have any idea how many of your folks, the state employees, are actually using compounded pharmacy drugs?
I do not, no. Because most of that is outside of the health plan. We see that, and
that's an elusive number for us as well.
Yeah, I would say it's probably significant, but it's just outside of what the plan is covering. These are usually individuals that are going to a compounding provider to getting it for weight loss.
And they're paying out of pocket.
Yeah, they're paying out of pocket, yes.
Any other questions? Any call-ins have a question?
I don't think we had any call-ins, sir.
All right, that's from the committee, or if there are no questions, anyone from the gallery have a question while we have Mr. Ashworth here? Everybody's quiet and happy and cold. Okay, I appreciate it. I'll be looking forward to getting any notes or comments that you would like to add to our report. If you would get those to Clif Richard, our clerk, and we will compile something, and we'll get that back to you so you can see what our report is. And if you want to weigh in one way or the other, should we continue with a new resolution or not, I certainly want to hear from you. I'm very interested in this, and obviously it is a significant issue. And I do appreciate the fact that we've been able to have this discussion, and I hate to use the term making us smarter, but it does make us much more informed on what's going on. And it is an important issue that I think, I know my constituents in District 81 are particularly interested in, and I think most folks in the state are. So thank you very much, and with that, we'll adjourn. Do I need to come down here and help you all vote?